Welcome to this clinical case discussion. Today, we will discuss a common condition seen in pediatric practice, nephrotic syndrome. Let's explore the case, starting with the history, examination findings, and provisional diagnosis. Let's begin. The case history. A 4-year-old boy named Ravi is brought to the clinic by his parents with a complaint of swelling. His mother noticed swelling around the eyes, which was more prominent in the morning. Over the past 2 weeks, the swelling has progressed to his legs and abdomen. His mother also reports a decrease in urine output. There is no history of pain, fever, or blood in the urine. 3 weeks ago, Ravi had a mild cough and cold, but it resolved without complications. On further questioning, appetite is normal. No history of trauma. No similar complaints in the family. Developmental milestones are appropriate for age. To summarize, we have a 4-year-old child with gradual onset swelling, reduced urine output, and a recent mild respiratory infection. The clinical examination. On examination, the child appears well and alert but has obvious swelling. Vitals: pulse 88 beats per minute. Blood pressure 100/60 mm of mercury. Respiratory rate 22 breaths per minute. Edema. Periorbital edema is present, most noticeable in the morning. Pitting edema is seen on the legs. Abdominal distension is noted, and shifting dullness is positive, suggesting ascites. The cardiovascular and respiratory system examinations are normal. Urine dipstick testing shows for plus proteinuria. There is no blood or casts in the urine. Provisional diagnosis. Based on the history and examination findings, the likely diagnosis is nephrotic syndrome, most probably due to minimal change disease, which is the most common cause in children. The key findings supporting this diagnosis are: generalized edema, decreased urine output, massive proteinuria on urine dipstick, normal blood pressure, recent upper respiratory infection, which may have triggered the condition. Next steps and management. To confirm the diagnosis, we would perform blood investigations. Typical findings in nephrotic syndrome include: low serum albumin levels, also known as hypoalbuminemia. Elevated cholesterol levels, known as hyperlipidemia. Management involves starting the child on oral corticosteroids, such as prednisolone. Most children with minimal change disease respond well to steroid therapy within 2 to 4 weeks. The prognosis is excellent, with the majority of children recovering fully with appropriate treatment. Conclusion. To recap, this was a case of nephrotic syndrome in a 4-year-old child presenting with generalized edema and massive proteinuria. Early recognition, confirmation, and initiation of treatment with corticosteroids ensure good outcomes. Now that we've discussed the clinical case of nephrotic syndrome in detail, let's move on to the Viva-style question and answer session. We'll start with common and easy questions, perfect for undergraduate medical students. Gradually, we'll dive deeper into advanced concepts, including molecular-level pathophysiology and postgraduate-level management. This structured approach will help you build a strong foundation and refine your understanding of this important pediatric condition. Let's get started. Viva questions and answers: nephrotic syndrome in pediatrics. Basic questions. Question 1. What is nephrotic syndrome? Answer: Nephrotic syndrome is a clinical condition characterized by four main features. 1. Massive proteinuria, defined as greater than 3.5 grams per 24 hours in adults, or significant proteinuria on urine dipstick in children. 2. Hypolbuminemia, which is low serum albumin levels. 3. Edema, which is generalized swelling. 4. Hyperlipidemia, which refers to increased cholesterol and triglyceride levels in the blood. Question 2. What are the common symptoms of nephrotic syndrome in children? Answer: the common symptoms include 1. Periorbital edema, which is swelling around the eyes, more prominent in the morning. 2. Generalized edema involving the legs, abdomen, and sometimes the entire body. 3. Reduced urine output. 4. Abdominal distension due to ascites. 5. In some cases, fatigue and poor appetite. Question 3. What is the most common cause of nephrotic syndrome in children? Answer: the most common cause of nephrotic syndrome in children is minimal change disease, which accounts for about 80 to 90% of cases. Question 4. How do you diagnose nephrotic syndrome clinically? Answer: nephrotic syndrome is diagnosed based on 1. Clinical findings of edema and reduced urine output. 2. Urine dipstick test showing significant proteinuria, usually 3+ or 4+. 3. Blood tests confirming hypolbuminemia and hyperlipidemia. Question 5. Why is morning puffiness of the eyes a common early sign of nephrotic syndrome? Answer: morning puffiness occurs because fluid shifts to the dependent areas during sleep, and periorbital tissue is loose and prone to fluid accumulation. Intermediate questions. Question 6. What are the complications of nephrotic syndrome? Answer: complications include 1. Infections, especially bacterial infections like peritonitis and cellulitis, due to loss of immunoglobulins. 2. Thromboembolism due to hypercoagulable state. 3. Acute kidney injury in severe cases. 4. Malnutrition due to protein loss. Question 7. What investigations are done to confirm nephrotic syndrome? Answer: the key investigations are 1. Urine dipstick test showing significant proteinuria. 2. Urine protein to creatinine ratio or 24-hour urinary protein estimation. 3. Blood tests showing hypolbuminemia and hyperlipidemia. 4. Serum electrolytes, renal function tests, and lipid profile. 5. Ultrasound of the abdomen to assess ascites and kidney size. Question 8. What is the role of kidney biopsy in nephrotic syndrome? Answer: kidney biopsy is usually not required in typical cases of nephrotic syndrome in children. It is indicated in 1. Children who do not respond to steroid therapy. 2. Presence of hematuria, hypertension, or renal dysfunction. 3. Suspicion of secondary causes of nephrotic syndrome. Advanced questions. Question 9. What is the pathophysiology of minimal change disease? Answer: in minimal change disease, there is damage to the podocytes, which are specialized cells in the glomerulus. The damage leads to the loss of the negatively charged glycoprotein layer on the glomerular basement membrane. This allows large proteins, particularly albumin, to leak into the urine. The exact cause of podocyte injury is unclear but may be related to immune system dysfunction. Question 10. Why does hyperlipidemia occur in nephrotic syndrome? Answer: hyperlipidemia occurs because of hypoalbuminemia. The liver compensates for the loss of albumin by increasing the synthesis of lipoproteins, leading to elevated cholesterol and triglyceride levels. Question 11. How does nephrotic syndrome create a hypercoagulable state? Answer: in nephrotic syndrome, there is loss of anticoagulant proteins, such as antithrombin 3, in the urine. Increased synthesis of clotting factors by the liver occurs. Platelet activation is increased. Together, these factors make the blood more prone to clotting. Question 12. What is the detailed management plan for nephrotic syndrome in children? Answer: the management includes 1. General measures. Sodium restriction to manage edema. Fluid restriction in severe edema. Nutritional support to prevent malnutrition. 2. Pharmacological treatment. Oral corticosteroids, such as prednisolone, at a dose of 2 mg per kilogram per day, usually for 4 to 6 weeks. Tapering the steroids gradually over several weeks. 3. Monitoring. Urine protein levels to assess response to treatment. Weight and blood pressure monitoring. 4. Managing complications. Antibiotics for infections. Anticoagulants for thromboembolism. Diuretics in severe edema, though cautiously to avoid hypovolemia. Question 13. What are the differences between nephrotic syndrome and nephritic syndrome? Answer: the key differences are 1. Proteinuria. In nephrotic syndrome, there is massive proteinuria greater than 3.5 grams per day. In nephritic syndrome, proteinuria is mild to moderate. 2. Hematuria. Hematuria is absent in nephrotic syndrome but present in nephritic syndrome, often with microscopic or gross blood in the urine. 3. Edema. Nephrotic syndrome causes generalized edema, while nephritic syndrome causes mild edema. 4. Blood pressure. Blood pressure is normal in nephrotic syndrome but elevated in nephritic syndrome. 5. Serum albumin. Nephrotic syndrome shows low serum albumin levels, whereas it is normal or slightly low in nephritic syndrome. 6. Urine output. Urine output is mildly reduced in nephrotic syndrome but significantly reduced, leading to oliguria, in nephritic syndrome. Now that we've covered the basic and advanced pathophysiology of nephrotic syndrome, let's shift our focus to the management aspect. This section will explore treatment strategies, monitoring, and handling complications in pediatric patients with nephrotic syndrome. Question 14. What are the goals of management in nephrotic syndrome? Answer: the goals of management are 1. To induce remission of proteinuria. 2. To prevent complications like infections, thromboembolism, and malnutrition. 3. To monitor for relapses and long-term steroid side effects. 4. To improve the quality of life for the child. Question 15. What is the first-line treatment for nephrotic syndrome in children? Answer: the first-line treatment is oral corticosteroids. Prednisolone is given at a dose of 2 mg per kilogram per day, up to a maximum of 60 mg per day, for 4 to 6 weeks. After this, the dose is gradually tapered over the next 6 to 8 weeks. Question 16. What is the expected response to steroid therapy in children with minimal change disease? Answer: Most children with minimal change disease respond to steroid therapy within 2 to 4 weeks. A complete response is defined as the disappearance of proteinuria on urine testing. Question 17. How do you monitor a child during steroid therapy? Answer. Monitoring includes 1. Daily urine protein testing using urine dipstick. 2. Regular weight measurements to assess edema. 3. Monitoring for side effects of steroids, such as weight gain, hypertension, hyperglycemia, and behavioral changes. 4. Blood pressure measurement and growth monitoring. Question 18. What is steroid-dependent nephrotic syndrome, and how is it managed? Answer. Steroid-dependent nephrotic syndrome refers to children who relapse during steroid tapering or within 2 weeks of stopping steroids. Management involves 1. Prolonged low-dose steroid therapy. 2. Use of steroid-sparing agents, such as levamisole, cyclophosphamide, or calcineurin inhibitors like tacrolimus or cyclosporine. Question 19. What are the indications for using immunosuppressive agents in nephrotic syndrome? Answer. Immunosuppressive agents are indicated in 1. Steroid-dependent nephrotic syndrome. 2. Frequent relapses despite steroid therapy. 3. Steroid-resistant nephrotic syndrome, where children do not respond to steroids. Question 20. What measures are taken to manage infections in children with nephrotic syndrome? Answer. Children with nephrotic syndrome are prone to infections due to loss of immunoglobulins in the urine. Management includes 1. Prophylactic vaccination against pneumococcus and varicella. 2. Prompt use of antibiotics for bacterial infections. 3. Ensuring good hygiene practices and early medical attention if fever develops. Question 21. How do you manage edema in nephrotic syndrome? Answer. Edema is managed by 1. Sodium restriction in the diet. 2. Judicious use of diuretics, such as furosemide, in cases of severe edema. 3. Albumin infusion in cases of hypovolemic shock or severe hypolbuminemia. Question 22. What is the long-term prognosis for children with nephrotic syndrome? Answer. The long-term prognosis depends on the underlying cause. 1. Children with minimal change disease have an excellent prognosis, with most achieving complete remission. 2. Relapses are common but can be managed effectively with steroids or immunosuppressive therapy. 3. A small percentage may progress to steroid-resistant nephrotic syndrome, which can lead to chronic kidney disease. Conclusion. This concludes the Viva-style discussion on nephrotic syndrome. We covered basic definitions, clinical features, and advanced management strategies. Understanding these concepts is key to confidently handling nephrotic syndrome cases in pediatric practice. Before we wrap up, I want to remind you to always cross-check the answers and concepts discussed here with standard textbooks like Nelson Textbook of Pediatrics or IAP Textbook of Pediatrics. These trusted resources will ensure accuracy and deepen your understanding. Use this discussion as a guide, but make sure to refer to authoritative texts for comprehensive learning. Keep studying, keep growing, and see you in the next session. To get the most out of this clinical case discussion, I recommend listening to it repeatedly. Repetition helps reinforce concepts, improve recall, and build confidence, especially for exams and clinical practice. Each time you listen, you'll absorb something new and strengthen your understanding of nephrotic syndrome. So, play it again, take notes, and let it sink in.